think it's probably not good to negate it. I think it's going to be there for a long time, and I think it's going to be something where we have to think about how to integrate it in with our guidance systems and our robotic technologies to some degree as well, because I think it's going to be there to stay, and it's one of the few modalities that really works well in the workflow.
Wonderful. Well, Professor Miga, thank you very much for joining us today. Really do appreciate your time.
No, my pleasure. Thank you.
Okay. Moving on and keeping best to time, we have Professor Ron Oterovitz online. Now he is professor up at the Department of Computer Science, University of North Carolina at Chapel Hill. And he is here today to talk to us about Towards Autonomous Robots for Healthcare. Professor Oterovitz, good to see you, sir.
Okay, thanks for the invitation. Do you see the slides and do you hear me well?
Correct.
Okay, great. So again, I'm Ron Oterovitz, and my research focuses on enabling robots to operate autonomously. So today I'll focus on our work on automating procedures, medical procedures in living tissue. So we already have a variety of autonomous systems. One example is a rocket, which can autonomously control itself without human intervention to reach a specific orbit in space. However, if we want to reach a specific site deep within the body endoscopically, no current commercial platform is capable of doing this autonomously in humans. Enabling medical robots to autonomously move through a body to accomplish a task is really hard, essentially harder than that rocket launch example. And creating autonomous robots, though, could have significant benefits, including enabling greater precision and accuracy, enabling new treatments and procedures, reducing medical errors, enabling remote healthcare, and potentially lowering costs. So what do we need to do to enable a medical robot to autonomously complete a surgical or interventional task? Let's start by looking at how medical robots typically operate today. So a physician typically teleoperates a robot, which is then operating on the patient. And to make the decisions, the physician uses a variety of data sources, such as sensor data, including visual, auditory, tactile data, medical images, medical records, and so forth. If we want to create an autonomous medical robot, we need to add an AI, and this AI can then look at the same data as well as feedback from the physician to control the robot. And as we make the AI more powerful, we can decrease the amount of control and feedback we need from the physician, increasing the level of autonomy of the medical robot. So let's take a closer look at the AI. There are many approaches we can take to enable autonomy. So one approach is a model-based approach where we develop kinematic models of the robot and create 3D models of the anatomy and develop planners and controllers that use those models. Another approach is to use learning-based approaches where we create neural nets that directly map the data to actions for the robot. So I'm going to talk about our approaches that we use, and I'll make the case that we need to use all of these different types of computer science and engineering approaches to address the challenging problems of automating medical procedures. So let's look at the motivation for our autonomous medical robot, which is lung cancer. So lung cancer is the deadliest form of cancer in the United States, killing more Americans each year than colorectal, breast, and prostate cancer combined. So early diagnosis is critical for survival. So achieving a definitive diagnosis of lung cancer currently requires a biopsy, which requires guiding a device into the lung to obtain a tissue sample to verify the presence and stage of the cancer. A traditional approach to biopsy is transthoracic biopsy, in which a physician inserts a straight needle into the lung between the ribs. This often results in errors in guidance and also requires puncturing the pleura, which is the outer membrane of the lung, which can lead to a serious side effect of lung collapse. An alternative approach is a trans-airway approach, in which a bronchoscope is deployed through the airway. This reduces the risk of lung collapse by not puncturing the pleura, but often cannot reach many nodules, particularly in the peripheral or outer parts of the lung. So modern robotic bronchoscopic systems can reach more targets, but still not everywhere. So my research group is combining the best of both of these approaches by creating a device in which a steerable needle is deployed through a bronchoscope and can steer to a nodule anywhere in the lung. And so this was research supported by NIH, and it was led by my team at UNC Chapel Hill, also in collaboration with folks at Vanderbilt, and also Alan Kuhns, who worked on it while at UNC, now at Utah, who will also be talking later this morning. So here's a picture of the robot. We see the robot actuation unit, which controls a steerable needle. That steerable needle then gets deployed through a conventional bronchoscope, and it comes out the other end where it can steer through the lung tissue. So the key enabling hardware in this system is the steerable needle. This video here shows several manual needle insertions into gel to demonstrate some of the capabilities of these flexible steerable needles. So deployment of the robotic system consists of 3 stages. So first, the physician navigates the bronchoscope. In the second stage, the physician pierces the airway wall and embeds the needle in the parenchyma. And then finally, in the third stage, the robot autonomously steers the needle to the target along a safe path. So we're going to focus here on the autonomous stage. And the idea with autonomy here is pretty simple, that we want the physician to be able to push the go button, and then the robot takes over and autonomously completes the task. So here we see a simulation video of a procedure to reach the nodule in the lung for biopsy. So steering the needle, which we see here, trying to avoid those blood vessels and reaching that yellow nodule, in many ways resembles steering a car, but now we must do it inside the anatomy in 3D in very cluttered tissue, where we must avoid obstacles like significant blood vessels. We also must handle respiratory motion, which is like the entire environment forming. So we created this robot platform and we assessed its performance in living and breathing lungs, in which we conducted a set of in vivo system deployments. So here's a photo of the experimental setup. We performed a live study using a live pig, which has lung anatomy similar to humans. You can see the robot actuation unit, the bronchoscope, a scanner cut off on the right, and then also a magnetic field generator and sensorized fiducials, which allow us to track the needle and perform registration between the CT of the lungs and the actual lungs. So this study showed the first medical robot to autonomously steer a needle and avoid obstacles in living tissue. This was published in Science Robotics under a year ago. You can see the link there if you want to sort of download the paper and read more about the details. To summarize some of the high-level results, not only did the robot succeed in performing the first autonomous needle steering in living tissue, it also performed quite well, achieving high accuracy. Here we use a penny as a reference to better conceptualize the scale of the errors. Overall, we performed 3 needle deployments and 2 in vivo experiments. The average targeting error for these insertions was under 3 millimeters, which is below the threshold for accurately reaching the smallest clinically relevant nodules. These results demonstrated our system's ability to successfully operate autonomously in living lungs undergoing respiratory motion. Next, we want to answer the question, can an autonomous robot improve procedure outcomes? So we compared our robot to an existing clinical bronchoscopy method. We conducted a comparative study in ex vivo pig lungs, and this photo shows here the experimental setup, which was similar to the in vivo setup. We measured the error in reaching the target for both our robotic automation approach and a current manual bronchoscopy approach. Using the penny for scale again, we see the manual deployments had a high targeting error, with physicians indicating that many of these biopsies would not have been attempted if this was in real patients. Our robot using automation achieved a much better accuracy compared to the current bronchoscopic technique. So now let's look under the hood on how we made this system work. So first off, a disclosure. So I am an inventor on university-owned patents on medical robotic devices that incorporate steerable needles. So in our workflow, we first take a preoperative CT scan, and then we segment the anatomy to construct an environment for our motion planning algorithm. From the CT scan, we can automatically segment the relevant obstacles, including the large blood vessels, the pulmonary pleura, which is the outer membrane of the lung, and the bronchial tree. We can also segment non-critical structures that would be nice to avoid if possible, like smaller blood vessels, which can be encoded in a cost map for comparing feasible plans. Then, based on the segmentation, we plan several safe paths given the hardware capabilities of the needle. We use a robotic steerable needle capable of following curved paths through tissue, as shown in this X-ray image here. This particular needle has two key properties. It has an asymmetric bevel tip, which causes the needle to bend as it is pushed into soft tissue, and it is highly flexible, so it curves a lot. We can twist the needle at its base to change the direction the bevel is pointing, which enables us to change the direction of the steering and follow curves like the one in the X-ray image. The task of the steerable needle motion planner is then to compute a 3D trajectory that complies with the kinematic constraints, avoids the anatomical obstacles, and precisely reaches the target site. So one approach we have used is to adapt a rapidly exploring random tree, or RRT type method, for steerable needles, which is a fairly standard approach for motion planning for robots. This is sort of a 2D illustration here, but this is all being done in reality in 3D. For each of these voxels here, we can highlight some of them are obstacles, meaning they're like these larger blood vessels. Some of them are free space, which is parenchymal tissue through which the needle can navigate, and we want to reach the orange circle there. So the RT-based method starts to explore this space. If it runs into an obstacle, then it basically says it's not going to go further in that direction. This is all done computationally until we eventually find a solution that reaches the target. And these types of exploratory methods like RRTs, again, work very well in practice, and we can get plans in sub-second times, but they don't offer very many guarantees. In particular, it can only guarantee that it will eventually find a solution. And so really we want to know is, can we do better? So we ideally would want to find an optimal motion plan in a fixed finite amount of time, guaranteed. So we've been developing methods to essentially create certifiable motion planners, providing certifications and guarantees on motion planner performance, which is important for medical applications and autonomy to be adopted clinically. So how do we achieve this sort of guarantee on performance? So as a step toward this goal, we investigated a search-based approach. So our method uses needle-specific motion primitives. A motion primitive defines a motion, in this case, that first rotates the needle to determine its curving direction and then inserts the needle. These are needle-specific in this case. We build now a search tree that repeatedly applies these motion primitives, and we refine the motion while expanding the search tree. So we implemented some speedups that make this method fast in practice and guarantee returning an optimal solution in finite time. So up until now, we focused on the autonomous needle deployment, which is the third stage of the robot. However, when the needle starts in stage 3, it depends on the earlier stages. So in particular, where should the physician park the bronchoscope and pierce into the parenchyma or the tissue of the lung? This defines the start pose of the needle and has an impact on whether the needle can successfully reach the target. So to determine where to park the bronchoscope, we created a motion planner that considers all 3 stages of the system deployment, from the bronchoscope to the piercing into the parenchyma to the needle steering. For efficiency, we plan backward from the target onto the surface of the airway, which is actually faster because we're going from essentially a point to a surface for planning, and that's much faster than trying to plan from a particular launch point to a particular target. We can then execute the plan that we found in the forward direction, but we've already taken advantage of this speed up in computation. Parking the bronchoscope for needle deployment is essentially a handoff of control of the needle from the physician to a robot. And how this handoff is performed has an impact on the success of the procedure. So to make the handoff as robust as possible, we can compute funnels around potential plans, such that if the bronchoscope launches the needle from any location where the funnel intersects the airway, then the autonomous steerable needle will be guaranteed to be able to find a plan that reaches the target while avoiding the obstacles. This is essentially a form of communication where the autonomous robot is telling the human physician its capabilities on a patient-specific basis, so that the handoff from where the human is controlling the system to where the robot is autonomously controlling the procedure will result in an overall successful procedure. So we've now discussed all 3 of the planning stages. One thing that I didn't mention that's critically important here is respiratory motion. All the planning was done in a static environment based on what I spoke about so far, but in reality, the patient is breathing, creating a highly dynamic environment. So our approach is to only advance the needle when we are in a known lung deformation state. So specifically, we use the inhalation state, which corresponds to the image that was segmented, which is also when the lung is biggest. So here we track the fiducials, basically these EM trackers that we have on the chest wall of the animal. And we use breath holds, which you see sort of for the first about 8 seconds or so. There's a breath hold, so they aren't moving. Then we allow 2 breaths. And then you see sort of hold steady for about another 8 seconds or so. Then we have 2 breaths, and we sort of repeat the cycle. We are then only going to